Hello, and welcome to the Check Rare podcast. My name is Peter Suzuki, and the topic of today's discussion is Fabry disease, a rare inherited lysosomal disorder that affects many organs, including the heart, kidney, and nervous system. It is a progressive and lifelong condition. This is the second part of our series focusing on Fabry disease, and today we'll be talking with Dr. Nicola Longo, Chief of the Division of Medical Genetics at the University of Utah Spencer Fox Eccles School of Medicine in Salt Lake City. Dr. Longo will discuss Fabry disease, including the progression of the disease and personalized medicine. Hello, Dr. Longo. Thank you for your time today. Can you introduce yourself and tell us about your work?
My name is Nicola Longo. I'm a professor of pediatrics at the University of Utah in Salt Lake City. I'm also the chief of the Division of Medical Genetics. I started working with Fabry disease and other lysosomal storage disorder more than 30 years ago, and I've been part of several clinical trials to try to bring new therapy to help patients with Fabry disease.
What would you like healthcare providers to understand about Fabry disease, especially about its mechanism as it relates to progression and patients' outcomes?
What we would like to understand is really if we can not only prevent progression of the disease, but also cause improvement in existing symptoms. The problem is that in general, with this condition and with the therapy that we are currently available, once a diagnosis is made, many times there are irreversible damages to many organs, and those cannot be undone. What is necessary is really early diagnosis and intervention with what we have today. In addition, if we could develop therapies that can reach better all organs, it might help more patients with Fabry disease in getting better, not progressing, but getting better from the state in which they start.
What parameters do you use to measure patients with this disease?
So first of all, we have to establish a diagnosis, and the diagnosis is usually done by DNA testing and by enzyme assay in males only. In females, enzyme assay is not reliable. What the specific mutation causing Fabry disease can tell us is, number one, as this mutation has been associated with classic Fabry disease or some milder variant of Fabry disease, keeping in mind that even the milder variants are not really mild, they are still severe. The second thing that we do, we measure what accumulates in Fabry disease. Until a few years ago, we only had one compound, which is called GL3. Now we have another one, which is called lyso-GL3, which is much more sensitive than GL3 to determine how much storage material is accumulating in patients with Fabry disease. The more you accumulate, the more likely you are to have complications of Fabry. Obviously, if we had a very effective therapy, we would be able to reduce this accumulation to prevent progression and possibly to start getting additional improvements.
So when a patient is diagnosed, what is the treatment regimen?
First of all, we try to assess all organs. Fabry disease, it is known to affect the kidneys, and the kidneys are the organs that are affected first. But now we know that it affects the heart very much, and the brain as well, causing strokes. So the first thing that we do, we try to assess what is the damage to this organ by blood chemistry and urine chemistry, and also looking at the heart by echo, and most of the time at the brain by MRI. And then we start therapy with enzyme replacement therapy. In Fabry disease, patients miss an enzyme which is called alpha-galactosidase A. And what we do, we produce alpha-galactosidase A in the lab, and the compound that it is, the biological product that it is generated, is then infused to patient every other week by an IV. This is the therapy that basically gives back the enzyme that it is missing in them. The problem with the therapy is that obviously it is intermittent because you give that every 2 weeks, and it is not always there. In addition, some organs, such as the brain, they do not receive much enzyme replacement therapy. There are additional therapies that we do in this patient that are the therapy that we do in patients that have a propensity to stroke. Sometimes we start baby aspirin, sometimes we start clopidogrel. In other cases, we have to use Eliquis. But in general, those are in addition to the enzyme replacement therapy, that it is the causal therapy. There is also an FDA-approved medication for patients who have certain mutations in the Fabry gene. There are certain mutations in which giving a small chemical increases the residual enzymatic activity of the mutant enzyme. And that obviously is very easy to use and very simple. But again, only a minority of patients have this type of mutation. The majority of patients will require lifelong enzyme replacement therapy.
How do you monitor the effectiveness of these treatments, and how do you define a treatment response?
So the way that you monitor, obviously, you look at the patient and you see how they are doing in terms of symptoms. And the symptoms that the patient have, many times they don't kill them, but they cause a lot of problem, because the first symptom that males have is pain in the extremities, very severe pain. So severe that many times patients require opioid to treat the pain, especially when they have no idea why they're having the pain. Others have irritable bowel syndrome that can be very problematic. But the organs that we monitor, but those are both conditions that are difficult to monitor using a lab test or imaging. What it is easy to monitor is the kidney function, the cardiac function, and the brain scan, because what we can see is if there are abnormalities at baseline and how they are progressing. In addition, in Fabry disease, you have the accumulation of different type of material, one of which is the lyso-Gl3, and we monitor the level of this compound with time. In general, when we start enzyme replacement therapy, this compound decreases until it stabilizes at a certain level that it is usually above normal, but it is still reduced from the baseline. If we see a spike, then we suspect that there is a problem. Which problem can happen with enzyme replacement therapy? The main problem is the production of antibodies that bind the enzyme and prevents its activity. So if that happens, obviously the enzyme does not work anymore, and you have worsening of the disease, in addition to infusion reaction sometimes. So in other words, you develop some hypersensitivity reaction to the infusion.
Since Fabry disease is a multi-organ disease, what specialists would you recommend that patients see?
Patients with Fabry disease are seen by many different specialists. In the pediatric age, many times they're seen by rheumatologists simply because they have the pain in the joint that they cannot figure out what that is. And the rheumatologist usually, once the diagnosis is established, transfer the patient to medical genetics because it is really not a rheumatic disorder. The specialists that need to see and follow these patients are the nephrologist, obviously to follow the kidney function, the cardiologist to follow the heart function, and then any other specialist depending on the type of evolution of the disease. Many of our patients have severe pain, and many of them are seen in the pain clinic to administer powerful anti-pain medication. So those are the main specialists that usually follow this patient. This is obviously in addition to the medical or biochemical geneticists that determine directs the enzyme replacement therapy.
How often should Fabry disease patients be seeing their specialists, their physicians, or whoever's monitoring their care?
It depends of their progression of the disease. So at the beginning, we see them relatively frequently. Frequently is twice a year, which is not very frequently at all. And then once we know that the patient is doing well with the enzyme replacement therapy, tolerating as well, we try to modify the way that we give the enzyme. And one of the things that we can do, we can speed up the infusion time if people tolerate it well. The second thing, at the beginning, we usually give pre-medication that are drugs that help fighting immune reaction, drugs such as fexofenadine, omeprazole, ibuprofen, acetaminophen, and sometimes Benadryl. So what we do, if the infusion is tolerated, we try to decrease the drug and to speed up the reaction time. And that it is why at the beginning we see them a little bit more. Once they are stabilized at a relatively fast rate of infusion, we see them once or twice a year, which is not very often, I think.
Does immunogenicity play a role in the management of Fabry disease?
Correct. If a patient reacts to the enzyme is given but binds to an antibody. And when it binds to the antibody, it cannot work anymore. So usually when we give the enzyme is taken up by the cell, goes inside the cell where it starts working and being effective. If you bind to an antibody, the enzyme will not get there, will not get inside the cell, and will not be effective. Obviously, there are all gradations in between. So in other words, a certain amount of enzyme will still be able to get to the cell and to be effective, but it is much less.
Do you think immunogenicity increases the risk of infusion-related reactions?
Immunogenicity does increase the risk of infusion-related reaction, simply because once we start reacting against the enzyme replacement therapy, we can release histamine that can be responsible for anaphylactic reaction or other types of hypersensitivity reaction. Decreasing the immunogenicity would help making sure that patients continue to receive benefit from enzyme replacement therapy. I had patients who developed severe immunogenicity 4 or 5 years after starting enzyme replacement therapy. In the majority of cases, it happened earlier than that, but not necessarily. So having a product that it is less immunogenic obviously would help making sure that the effect of replacement therapy continues with time.
How do adverse events and tolerability issues impact care for Fabry patients?
The majority of patients tolerate the infusion relatively well. They don't have much of a problem. But we have a minority of patients that might be 5 to 10% who might even have to stop enzyme replacement therapy because they cannot tolerate it. And when that happens, the disease progresses. And you have a worsening of kidney function and especially worsening of the cardiac function. The heart has always been a problem in Fabry, but before enzyme replacement therapy, most patients develop kidney failure before developing heart failure. Now what we are seeing is that with enzyme replacement therapy, the kidney continues to last longer, but many patients develop cardiac complications. So having a product that is less immunogenic could decrease the risk for this complication.
What are anti-drug antibodies?
anti-drug antibodies are the response of our body to a foreign antigen. They happen not just with drugs, they happen with anything that our body has never seen. What we do, we process what comes from the outside. There is a special system of cell that breaks down what it is given extra, which we call antigen, and present it to antigen processing cell that will mount an antibody response. And the antibodies will interact with the foreign protein to try to neutralize it. In general, this process is the one that we use to fight viruses, to fight bacteria, to fight anything that can harm us. Obviously, the body does not know that enzyme replacement therapy is a good thing for us, for the patient with Fabry. And that it is why they see the enzyme replacement therapy as a foreign antigen that needs to be destroyed. So antibodies are the way that the body tries to do to destroy anything which is not proper of the body.
And do you, as a caregiver, monitor for them, and how often?
So correct, we monitor for antibodies against the enzyme replacement therapy at the beginning very frequently, every 3 to 6 months. After a couple of years, we start monitoring every year at least, sometime every 6 months. And obviously, if there is worsening of the disease or if there are hypersensitivity reaction, we obtain extra monitoring for that. In this way, if we see the formation of antibodies, what we do, we try to adopt strategy to minimize antibody production.
And can you talk a little bit more about the implications that it has for the long-term care for your patients and how it changes your treatment decisions?
So when patients start developing antibodies against the enzyme replacement therapy, we need to try to desensitize them. Otherwise, again, they stop completely having the enzyme that they are missing and their disease will progress. And we have different strategy to desensitize the patient. And the strategy that we usually use, we decrease dramatically the dose of enzyme replacement therapy, and we increase the frequency of administration. What we try to do, we try to convince the body that the enzyme replacement therapy is part of itself, because it is always there. So you give it every week. I mean, the ideal situation would be to give that to a continuous infusion, and then at a very, very low dose. And then the body, with time, will develop specific cells that are called T regulatory cells that tell to the body, hey, this is part of yourself. Stop fighting this antigen. Stop fighting this enzyme replacement therapy. Many times we need to use steroids or other immunosuppressants to induce this tolerance. So obviously it depends on the degree of reaction that a patient has. But again, if patients do develop antibodies at high titer, we might not be able to give the enzyme replacement therapy because they have severe infusion-associated reaction. And even if they get the enzyme replacement therapy, it might not be able to work properly because the antibody might neutralize it.
Regarding the anti-drug antibodies, is there anything you would like to add to this discussion?
So the biggest issue is when we give enzyme replacement therapy, many of the enzyme replacement therapy left in the circulation a very short time. Meaning that you give it and after a few hours, they are totally gone. Meaning that, as I was telling you, the ideal situation is exposing the body to a relatively low but constant concentration of antigen to trick the body to think that it is part of itself and that product does not need to be formed. Obviously, having some type of enzyme replacement therapy that lasts for longer in the circulation might help circumvent this problem. So the main challenges is that, again, it is a multi-organ, there is multi-organ involvement. The best person to treat many of these conditions is the primary care provider that usually is not experience in the treatment of rare disorder. But for example, his experience in treating high blood pressure, his experience in treating proteinuria. So, but usually what we do, we try to get a nephrologist involved and they communicate back to the primary care provider. Now, with electronic medical record, it's relatively easy to see what another consultant has said, because you just click on the notes and you see what are the recommendations of the other specialties. But mostly what the medical geneticist does every year when they see the patient, they make sure that this system of communication are in place. And if something is defective, we try to fix it. The nephrologist thinks to the kidney. The cardiologist thinks to the heart. The primary care physician thinks to common problem. The geneticist try to put all of them together to coordinate the care for the patient, making sure that examination that need to be performed are performed, and imaging that needs to be done gets done. And then if there is a problem, obviously the specialist will decide what to do to ameliorate the problem.
What does personalized medicine mean to you, especially in regards to rare disorders such as Fabry disease?
Patients with rare disorder, which obviously includes Fabry disease, need personalized medicine. This both in terms of diagnosis and therapy. So first of all, some patients, depending on the specific mutation, might be amenable to oral therapy, and obviously that it is an easy solution for this patient. The second thing is that depending on the response to the enzyme replacement therapy, which applies to the majority of patients, some of them might do better with one type of enzyme replacement therapy. Some other might do better with a different type of enzyme replacement therapy. One of the issues that sometimes we tend to forget is that enzyme replacement therapy requires them to visit an office, an infusion center, or to have somebody at home performing the infusion for them every 2 weeks. In addition, some patients, the day of the infusion, simply because some of them take pre-medication or other drug, they really wear out. So basically, it is a burden on the patient to receive enzyme replacement therapy. If one could give less frequent enzyme replacement therapy, that would help them having a better quality of life, because it would add 1 day every 2 weeks to their life. So obviously, that it is what really means to do personalized medicine in these cases. So look at which one is the best drug for them, and then try to see how their complication progress. So making sure that additional medication are added on for complication. What we do, we try to test for complication at the beginning. In other words, before they really have damaged an organ. So in this way, we look for them early on. We want to prevent the most severe complication. One of the problems that many of these patients develop with time is that their heart rate drops very much. Their heart starts beating very slowly. And what we found is that placing a pacemaker on demand increased dramatically their capacity to do anything, because they feel a lot more energy. I mean, if your heart beats 40 times a minute, you cannot do very much. If it beats 60 times a minute or more, then you can do much more. So personalized medicine means looking at the problem that have been associated with this disease, making sure if they are there or not, and if they're there, treat them early before there is irreversible damage.
Thank you, Dr. Longo, for your insight into Fabry disease and your thoughts on personalized medicine. This concludes our second part of our series on Fabry disease.